What patients do I consider? That's a really important question. If you look at the population, subset of population, up to now, in the adult data set in the abstract, we've now identified at least 13 different tumor types. Likely, there will be even more tumor types in an upcoming data set at ESMO, up to 22 different tumor types. If you look and break down the type of tumors and the type of patients that are seen, one, there are types of tumors that are almost pathognomonic. That means almost diagnostic of that disease with NTRK. For example, mammary analog secretory carcinoma, that's a mouthful, called mask tumors. They're oftentimes misdiagnosed as standard head and neck cancers, salivary gland tumors, or parotid tumors. But they have a distinct feature histologically, but invariably if you test them for NTRK, they will have NTRK fusions. Many of these patients present early, and so they are cured by surgical resection. But a number of these patients will eventually develop metastatic disease, and at that point there's really no standard therapy for them. And so I think that's one key. And there's also a whole class of histological tumors similar to MASC. Secretory breast, for example, is another type of cancer that probably harbor MASC tumors. Other almost diagnostic or pathognomonic diseases include rare tumors, such as pediatric infantile fibrosarcomas, pontine gliomas. They almost invariably have NTRK fusions. Obviously, the community oncologist will not see those patients, so they'll be oftentimes seen in an academic pediatric setting, but these patients will oftentimes have this. Then there's this other, probably the largest group of individuals, which are other solid tumors that can range from very common cancers like lung cancer, standard breast cancer, and thyroid cancer, and colorectal. There's not a clear, defined picture of who these patients are. With that said, I think there tends to be, tend towards patients who may be a little bit younger, tends to be on patients who you know, if you had standard mutational testing, for example, in lung, they don't have EGFR mutations. These patients don't have ALK-ROS translocations. They're really truly driven by NTRK fusions. So I think that's something to keep in light of is that these patients that the community oncologist sees, and they may have an in-house mutation set of analyte assays, and no mutations emerge. It may be worth sending it off if they don't have an NGS platform in-house to other, places like Foundation, places like Caris, to really see if there's the possibility of an NTRK fusion. So those are really the two kind of populations. Within that population of other common tumor types, there are nuances and details that are probably more detailed than is necessary in this presentation, but that's in general, those are the patients that we should be looking for. I recognize in the community not everybody is able to be tested, and it goes back to then identifying these patients as I described. But I think many of my colleagues, including some of the significant authors on this, on the papers that we've been in the studies chairs, such as Dr. Hyman, Dr. Shivani Kumar, Dr. Drillin, would argue that we should do our best to try to test patients, particularly if they've, all cancer patients, if they have metastatic cancer, right? Not only Larotrectinib, not only NTRK, but, and this ASCO has shown that increasingly we are seeing more and more effective targeted therapies. Lung has multiple targeted therapies now, and really kind of these large multiplex NGS platforms are really the best and most efficient way to identify these sometimes life-changing targeted therapies for our patients.